Okay, Assalamu alaikum everyone. I'd like to thank the convener, Dr. Bandisha, and the rest of the team to invite me here to come and present this important topic. And I'd like to thank the audience that you're braving it out this late at a beautiful venue like this. But my goal here in the next, I guess they cut down the time here from 15 minutes to around 12 or something like that, is to talk about echocardiography, what the current state is, and what some future applications are, since the theme of the conference this time in Bhurban is, update on many different things. So this is the update on echo. So echocardiography, I think everyone here, I like to know my audience. So how many people in the audience actually read echo? Anyone? Basic, okay. Okay, so a few. Everyone knows then that it's a first-line bedside tool for the diagnosis of heart failure patients, and the assessment of prognosis with ejection fraction have been the cornerstone of heart failure definition. There's a lot of talk about heart failure at the conference this time, and so many of you are aware that you really can't really do anything if the diagnosis is not made. It's very important for valve disease evaluation, diastolic assessment, as well as the value in diastolic exercise testing that is performed at some institutions. Pulmonary artery pressures are of crucial importance, and obviously this becomes a screening test for PA pressures, though it's not the gold standard. But the things I want to highlight today are some of the newer things like strain echocardiography and then the guiding of structural interventions. So this is a central illustration taken from Jack Heart Failure. It was published in 2021 that nicely summarizes where all the different cardiac imaging modalities fall. So we have volumetric characterization up here, chamber volumes, ejection fraction, stroke volume. So here you see an MRI image and some 3D images here. We have flow and pressure characterization. So that's where the Doppler comes in. Everyone here who reads echo knows this is diastology. Tissue tracking is one of the, we used to say newer techniques, but now it's been around for a few years. And here's where we calculate out strain and strain rates, which is what we see here. And I'm going to touch a bit on this. And strain is actually a parameter that might become abnormal before the patient's ejection fraction drops. So this is tissue tracking. And then I think one of the most important is actually tissue characterization. And this is where we can look at things like myocardial stiffness, ischemia and hibernation, and really tell if something is scar or viable tissue. And that, as you've heard in some of the earlier sessions today, MRI is the gold standard for tissue characterization. So, here are some images. Here on the left panel, there's an image here of an unenhanced biplane planimetry. In the middle, we have enhanced planimetry. And then on the right here, we have 3D ejection fraction. So the middle panel has enhanced, and this is contrast, echo contrast agents that we currently do not have available in Pakistan, but that's something that we're trying to work with some vendors to see if we can get that for our patients in whom visualization of walls is difficult. Now, here is an example of a bullseye plot taken from a patient's tissue technique. So for those in the audience who are not familiar with it, what we're looking at with strain is we're looking at the shortening of a myocardial fiber. And so when it shortens, it should get, the number becomes negative. So a negative number is normal. So if it's negative 18, negative 19, that's considered a global longitudinal strain that is normal. So this patient is on breast cancer chemotherapy, and on doxorubicin, a normal plot should be all red. And this is off doxorubicin. Once the patient is taken off, some of that normal area returns. In the middle of this is, the apex of the patient, and then as it moves out towards the periphery, that's the base of the patient. So again, tissue tracking and strain techniques help us identify different types of pathologies, but what I've demonstrated here is that on a patient on cancer drugs, on cardiotoxic therapy, one of the faster, not faster, but one of the earlier ways of picking up a decrease in function, even before the ejection fraction drops, is to measure the patient's strain. And then there's clues to other diagnoses that are difficult to make. So I think many of you who are imagers here know that cardiac amyloidosis can sometimes be difficult to diagnose. One of the cornerstones of cardiac amyloidosis is cardiac MRI, which is not easily available everywhere. And then, of course, there's TTR image, for TTR amyloidosis, there's technetium pyrophosphate imaging, which is again not available in all labs. And so on echo, is there something we can do that can hint that the patient has cardiac amyloidosis? Cardiac amyloidosis gives us thickened ventricles, and it can mimic conditions like chronic hypertension and other types of diseases. So if you get this apical sparing pattern, so again, I told you on the last images that red is normal. So the middle here is the apex, and if this area is normal, then it essentially means that the apex is spared compared relative to the base, and that might be suggestive of cardiac amyloidosis. Now, here you see what is a 3D reconstruction using echo on a right heart of a patient. Many people who do echo understand that the right ventricle is difficult to visualize, and right ejection fraction and fractional shortening are all difficult to measure. And so some of the companies have come up with software where once you put a trace around it, it gives you this 3D construction similar to a left ventricle and can tell you ejection fraction. And in this image, these are images that I took in my lab in the US before I moved to Pakistan. We used contrast echo very frequently if in more than 2 segmental segments we were not able to visualize the ventricle. So if there were any 2 segments that were not visualized, we had to do contrast. So that again, as I mentioned, is something we're trying to bring. Now let's move on to structural intervention. So many of you are interventionalists, and you know this has been an exciting advancement in terms of things that can be done without doing a sternotomy. So those include TAVR, ASD closures, VSD closures, perivalvular leak closures, and what you see up here in the imaging panels up here are the mitral therapies like mitral clip or similar to a mitral clip, the clasp, the Pascal device, which is similar to a mitral clip, then basically clips the mitral valve and forms what is similar to an Alfieri stitch that is placed during surgery, giving us this sort of figure, sort of 8 owl's eye pattern, where you just take a widely open mitral regurgitation orifice and convert it into 2 smaller orifices. And so echo has basically, especially 3D echo, as I'm going to show you in some cases, really has become the cornerstone of structural imaging. It's used for the planning. So initially, when you're doing your annulus sizing, not every patient can get a CT with contrast. They might have kidney dysfunction. You could use a 3D TE to do that. For the ASD planning, for the size of the hole, as well as whether there's an aortic rim, a posterior rim, you need it. For the mitral clips, it's for deciding if it can be closed using a clip, if it's primary or secondary MR, where exactly the leak is. But there have been many other advances in imaging apart from the 3D application. So we all hear about artificial intelligence, and this has been incorporated into many of the machines now. And what happens now is that many different devices are able to quickly detect things, and I'm going to show you this on my next slide. Machines that manually used to measure ejection fraction and valve parameters can now do them automatically. But in addition to that, many of your patients are probably going to be wearing an Apple Watch or maybe have a smartphone that can measure their blood pressure, and there are phone applications out there now where we can do an echo. So I'm going to be talking about this point of care ultrasound where you can basically connect the probe to your iPhone or your Android phone and basically do an echo right from home. And in some institutions, in some countries, they've looked into this. If a patient needs a follow-up, can they go home with the probe, or can a community health worker or a primary care doctor help get the images? And then remotely, over a laptop, an expert can remotely help them with what they're seeing. And I'll show you some examples of that. And here are some of the advances that I was just mentioning that have happened on the machines as time has gone by. So between 1985 and this goes up to 2016, you can see that the ejection fractions on left ventricles have become automated, the chamber dimensions have become automated, the mitral regurgitation PISA volumes can be automated. And so many things, you just have to put in the basic parameters, and then the machine goes out and gives you that information. Point of care ultrasound has been an exciting area of advancement within echo. So many of you might have seen this device. It's called a butterfly device. This is available in Pakistan. And basically, this probe here, which can fit in your pocket, can connect to, an iPad, an iPhone, a Samsung or Android. It doesn't connect to phones that are not iPhone or Samsung because it's just the compatibility. But essentially, you can pretty much do an ultrasound of any part of the body. There's a drop-down list, and you can select cardiac, or you can select lungs if you want to look at pleural effusions. But basically, that's what you do. And then what you're able to do then, and we've done this, and I've actually, through one of my remote sites that has a butterfly, so this is not a picture of me, but basically on a laptop, I'm able to look at the images here that are being acquired by this echo tech, who is basically sitting in any of our satellites in Larkana or Sakhar or across the road in the Jinnah OB clinic. And so now we're talking about a technology that can, in areas where we don't have echo expertise and they need an opinion, they need you to give them, a second set of eyes to confirm that this is a pericardial effusion that needs to be tapped today, or this is a patient that needs to be referred to Karachi. This is a great thing. So this is the teleguidance that can be performed. So switching gears and coming back a little bit to 3D TEE, I think everyone in the audience who's done 3D TEE, and basically, once you do this, there's no going back. I think 3D TEE initially came up as something that was only available in some institutions, but in the West now, pretty much a TE has to always have 3D images. It doesn't matter if you're planning to close or not close, but at NICVD at this point, all our valve cases have 3D imaging, and most of the other cases too, with endocarditis or something interesting, we do it with our 3D probe, which, we have one at the moment, but we take really good care of it. And just to go back for a moment here, in the 3D, in the schematic here, you can sort of see that you can see every scallop, and that's what the goal is, to try to guide interventions by specifically saying, go between the A3P3 or A1P1. Now I'm just going to show you 3 brief cases here. I think I have about 3 minutes. This is a case of an atrial secundum defect. You can see a big hole here, and basically this is an en-face view of 3D on the right side. And this patient was actually closed using an ASD closure device, and you can see that during the procedure we can guide by doing measurements, but those are some 3D images of once it's been deployed. This here, I've put it in here to show you the technology and how good your images can be. So these images are acquired on our echo machine that we use at NICVD, and this is a patient with a mechanical bileaflet mitral valve. And I think you can all see how nicely you can see those 2 bileaflet discs opening on 3D. There's no doubt here. I think many of you remember, and I still remember in my training, patients coming in and we're like, oh, is one leaflet stuck or not? Can you tell on echo? I can't really tell. Okay, let's go fluoro them. And we always used to say fluoro is the gold standard. But I would argue when you have image quality like this and your leaflets discs show like that, then you probably don't need fluoro on that case. Here you see a case of what we see very commonly in Pakistan, critical mitral stenosis. Look at all that smoke in the left atrium. Huge atrium. This patient was around 28 or 29 years old. And this is the patient's smoke and turbulence that looks like a tornado that's captured on the patient's 3D images. And then this is again the patient's en-face view of mitral stenosis. And this kind of measurement that is performed from the atrial aspect or the ventricular aspect is a more accurate way of measuring the patient's mitral valve area. So remember, mitral valve area that is commonly used for assessment of severity is going to be your cornerstone in deciding, who gets a balloon valvuloplasty or gets referred for surgery. But you have to make sure your measurements are done correctly. And in this day and age, you should make sure that the area is acquired at the tips. Remember, if you cut it here, you're going to measure the wrong valve area on the patient. So sometimes in your labs where you work, you might see some discrepant, the mean doesn't match with the area, or the area is too high and the mean's too low. Make sure that your sonographer cut it at the tips or get a 3D TE. And not all cases of mitral stenosis get a TE, but these are examples of cases that were being considered for balloon commissurotomy, balloon valvuloplasty. All right, so this was a case, 45-year-old with heart failure found to be in new onset atrial fibrillation, referred to the lab for TE cardioversion. TE was performed. This is the patient's 2D images. And I would ask the audience if we had time here, but I'm just, for the sake of time, going to go ahead and highlight the abnormality. So you can see here, we have a posterior flail. And again, here you see the posterior flail. Right? It's pointing towards the atrium. There's no coaptation there. So we're expecting that when we put color on there, we're going to see severe mitral regurgitation, which we do. And because it's a posterior leaflet problem, the jet is going to be directed anteriorly. So remember, it goes in the direction opposite to where the pathology is. And so I think this is a clear-cut patient because of all of, and this is the 3D image that again, in the on-FOSS view, this is the anterior leaflet, posterior leaflet, and here's the flail segment. And I think everyone would agree this was a surgical case. This was not a case that we could do with a mitral clip, and this patient went to surgery and got a prosthesis, as is shown in this image. And so 3D is pretty good for looking at posterior prolapses, right? So here's another one, but this particular one underwent a Pascal device that is part of the CLASP trial, and this was actually a sort of a mitral clip kind of device where you go in, you find the mitral regurgitation jet, you grasp one leaflet, and then you grasp the other leaflet, and you clip them together. And this patient's severe mitral regurgitation was reduced to mild mitral regurgitation, because this was a patient who could not go to surgery. And then I think this is my last slide, and I'm out of time as well. This is an example of a case of the Tendyne valve that we performed, again, right before I moved. And this is, this is almost like a replacement that's done just like we do for TAVR. You go in there and in the mitral position, deploy this valve. And this is how it looks on 3D. It's really beautiful. It just sort of expands and then sits there in the mitral annulus, and it decreases the degree of mitral regurgitation. So again, in summary, there's a lot that has advanced in the field of echocardiography, and it's an exciting field for us. Thank you.